Welcome to BANEF Nursing. In this video, we will provide an overview of chronic obstructive pulmonary disease, COPD, which is composed of two diseases, chronic bronchitis and emphysema. We will clearly explain the pathophysiology, primary risk factors, clinical manifestations, diagnostic tests, complications, treatment options, and patient education. The pathophysiology. COPD is a progressive respiratory disease that causes obstruction of the airway and results in shortness of breath. Most people diagnosed with COPD have elements of long-standing emphysema and chronic bronchitis. COPD is characterized by long-term tissue degeneration of the bronchi tubes that leads to damage to the lungs and obstruction of airflow. It is good to note that it causes irreversible damage to the lungs, while the damage caused by asthma is reversible with treatment. Let us switch gears and review emphysema. Emphysema is an obstructive disease characterized by the destruction of the alveolar walls, which leads to air trapping and chronic hyperinflation of the lungs. The breakdown of the alveolar wall also leads to loss of surface area for gas exchange, loss of elastic fibers, and the inability of the lungs to recoil on expiration. The patient with emphysema finds it very difficult to exhale carbon dioxide, and oxygen cannot enter, which leads to ineffective gas exchange of oxygen and carbon dioxide. The patient with emphysema will have a barrel chest and sit in a tripod position to help ease the work of breathing. Please note that the majority of patients with emphysema have increased dead space in their lungs and impaired oxygen diffusion, which leads to hypoxemia. The retention of carbon dioxide in the bloodstream, hypercapnia, leads to respiratory acidosis. Also note that one of the complications of emphysema is cor pulmonale, right-sided heart failure. On the other hand, chronic bronchitis is a disease that affects the small airway, and it is characterized by the presence of cough and sputum production for at least 3 months in each of 2 consecutive years. Chronic bronchitis is caused by inflammation of the bronchi and bronchioles that leads to hypersecretion of mucus, which plugs up the airways and thickens the bronchial walls. We know that all lower airway disorders negatively impair oxygenation, ventilation, and gas exchange. Primary risk factors. History of cigarette smoking is the greatest risk factor. Increase in age. Exposure to toxins and inhalation of lung irritants. Occupational exposure to dust pollutants like asbestos and chemical fumes. Genetic factors like deficiency of alpha-1 antitrypsin. Living in a polluted area. Clinical manifestations. Shortness of breath, dyspnea on exertion or at rest, finger clubbing due to low blood levels of oxygen, cough, barrel chest due to loss of lung elasticity, and chronic hyperinflation, tripod position to ease the work of breathing and pursed lip breathing, anxiety related to difficulty in breathing, wheezing, inability to talk in full sentences, use of accessory muscles for breathing, weight loss due to severe dyspnea and fatigue, diagnostic tests, patient's history and physical examination, pulmonary function tests are used to confirm the diagnosis of COPD, determine the severity, and monitor the progression. Spirometry is used to evaluate airway obstruction, which is determined by examining the ratio of forced expiratory volume, FEV1, to forced vital capacity, FVC. Screening for alpha-1 antitrypsin deficiency should be done for all adults aged 45 years and older. Chest X-ray may be done to rule out other causes of respiratory distress. Arterial blood gas to obtain baseline oxygenation and gas exchange. Complications. Pneumothorax, hypoxemia, respiratory acidosis, respiratory infection. COPD may lead to pulmonary hypertension, right-sided heart failure, and cor pulmonale, dysrhythmias, respiratory failure. Treatment. Monitor pulse oximetry to determine the severity of hypoxemia. Provide low-flow oxygen therapy as needed. Note that oxygen is a medication, and at sea level, the concentration in room air is 21%. Monitor the arterial blood gas, ABG, to measure oxygenation, ventilation, and the lungs' ability to clear carbon dioxide. Administer inhaled bronchodilators, beta-2 adrenergic agonists, and anticholinergics as prescribed. Administer glucocorticoids as prescribed. Administer vaccine prophylaxis like the pneumococcal and annual flu vaccine to reduce the risk of exacerbation. During exacerbation, a sputum culture should be done to identify the causative organism. Administer antibiotics if prescribed for infection and exacerbations. Lung reduction surgery to reduce air trapping and improve expiration. Non-invasive positive pressure ventilation may be used to reduce the need for endotracheal intubation and ventilation. Patient education. Educate patients on smoking cessation and the consequences of secondhand smoke. Teach patients breathing techniques like pursed lip breathing. Encourage patients to monitor and report signs and symptoms of infection. Teach patients the safe use of oxygen therapy and to remove combustion hazards in the room. Teach the importance of medication adherence and encourage patients to take prescribed medications as scheduled. Teach patients to pace activities and do moderate exercise as tolerated. Thanks very much for watching. If you found this video interesting and want to support my channel, kindly click the subscribe icon, like, and share the video. Have a blessed day.